What if one of the most common things we prescribe in pulmonary medicine is being prescribed for the wrong number of hours? Welcome back to This Week in Pulmonary and Critical Care Medicine. I'm Dr. Aladdin Sagar, and this is your rapid, high-yield review of the most clinically relevant new literature in pulmonary and critical care. This week, we'll discuss whether prescribing oxygen for 24 hours per day actually provides meaningful value compared to 15 hours, despite decades of dogma around long-duration oxygen therapy. We'll then move into a major SCCM and ESICM Delphi consensus that attempts to standardize the definition of refractory septic shock, something intensivists talk about every day but have never truly agreed on. And finally, we'll finish with a broader pulmonary review looking at incidental pulmonary nodules and why health systems may be missing one of the largest opportunities for earlier lung cancer detection. 3 papers, 3 very different topics, but all of them force us to rethink how we define risk, escalation, and early intervention in pulmonary and critical care medicine. Let's get started. Long-term oxygen therapy has been one of the foundational therapies in severe chronic hypoxemia for decades. But one uncomfortable reality has persisted in the background for years. We have surprisingly little evidence guiding exactly how many hours per day oxygen should be prescribed. A new economic analysis of the Redox trial, published in the Annals of the American Thoracic Society in May 2026, tries to answer a very practical question. If 24 hours per day of oxygen is not clinically superior to 15 hours per day, does it at least cost more? The original Redox trial previously showed that prescribing long-term oxygen therapy for 24 hours per day was not superior to 15 hours per day in reducing mortality, hospitalizations, or improving patient-reported outcomes. This new paper specifically focused on cost-effectiveness. The investigators performed a cost minimization analysis using data from 241 patients with severe chronic hypoxemic respiratory failure, randomized to either 24-hour oxygen or 15-hour oxygen prescriptions. There were 117 patients in the 24-hour group and 124 in the 15-hour group, followed for 12 months using Swedish national healthcare registries. At first glance, many clinicians would assume the 24-hour strategy would inevitably be more expensive. More oxygen, more electricity, more equipment utilization. But the results were more nuanced. Patients prescribed 24-hour oxygen did have higher oxygen-related costs, with an increase of approximately $173 compared to the 15-hour group. However, those same patients had lower respiratory medication costs, reduced outpatient utilization, and numerically lower inpatient costs. Respiratory-specific medication costs were lower by about $175 in the 24-hour group. Most importantly, overall healthcare costs were not significantly different between groups. The total cost difference numerically favored the 24-hour strategy by nearly $5,000, although the confidence interval crossed 0. The authors also modeled national-level implementation and estimated potential cumulative savings of approximately $7.6 million if 24-hour oxygen therapy were broadly adopted. This is where interpretation becomes important. This is not a study proving that 24-hour oxygen is superior. It is also not a study proving that 15-hour oxygen is inferior. Instead, this is probably best classified as practice reinforcing, not practice changing. What the study really tells us is that reducing oxygen prescription duration from 24 hours to 15 hours may not generate the healthcare savings many people expected. That assumption appears overly simplistic. The accompanying editorial makes another important point. While costs may appear budget neutral at the system level, they may not be neutral for individual patients. The 15-hour group had numerically more respiratory medication use and longer hospitalizations, and that matters clinically. One major limitation is generalizability. This was performed within the Swedish healthcare system, where oxygen utilization patterns and costs differ substantially from the United States and many other healthcare systems. Another issue is adherence. Oxygen adherence was self-reported as high, but real-world adherence to prescribed oxygen duration is notoriously difficult to measure accurately. In practice, this means we still do not have compelling evidence that reducing prescribed oxygen duration from 24 hours to 15 hours meaningfully improves outcomes, convenience, or healthcare costs. For now, clinicians should probably avoid assuming that less oxygen time automatically translates into better value care. One of the most commonly used phrases in critical care medicine is refractory septic shock. The problem is that nobody has ever truly agreed on what it means. Some clinicians define it by vasopressor dose, others focus on lactate, others use persistent hypoperfusion despite fluids. And across the literature, definitions have varied dramatically. A major joint SCCM and ESICM Delphi consensus published simultaneously in Critical Care Medicine and Intensive Care Medicine in May 2026 attempted to finally standardize the clinical criteria for refractory septic shock. This was not a randomized trial. It was an international expert consensus process involving 56 multidisciplinary critical care experts using a 5-round Delphi methodology. The goal was simple but important: define the clinical phenotype of the sickest septic shock patients. And honestly, this matters more than many people realize. Without a consistent definition, research populations become heterogeneous, therapies get studied in very different patient groups, and bedside clinicians use terms inconsistently when communicating prognosis and escalation decisions. The panel ultimately reached consensus on several core features of refractory septic shock. First, refractory septic shock requires evidence of persistent tissue hypoperfusion. Lactate remains central, with consensus support for persistent hyperlactatemia. Capillary refill time also reached consensus as an important marker. Second, patients should be fluid unresponsive after initial resuscitation. Third, vasopressor requirements matter. The group agreed on norepinephrine equivalent doses greater than 0.5 micrograms per kilogram per minute as a defining threshold. And fourth, the panel supported critical care ultrasound assessment when mixed shock physiology is suspected. What makes this paper particularly interesting is not just the final criteria. It is the acknowledgement that septic shock exists on a continuum rather than as a binary diagnosis. There is also an important practical implication here. As vasopressor doses climb, clinicians begin considering adjunctive therapies like vasopressin, angiotensin II, methylene blue, corticosteroids, or even extracorporeal support. But without standardized definitions, the timing of escalation becomes highly variable. That issue is reinforced by an accompanying foreword discussing the lack of standardized vasopressor dosing units internationally. Some institutions use weight-based dosing. Others use fixed dosing in micrograms per minute. That variability changes how clinicians perceive high-dose norepinephrine and potentially influences when therapies are escalated or withdrawn. This is a subtle but very important systems-level problem. Now, this paper is probably best classified as hypothesis-generating rather than immediately practice-changing. Consensus statements are still expert opinion. They are not outcome-validated diagnostic criteria. And importantly, the chosen thresholds remain somewhat arbitrary because they emerge from expert agreement rather than prospective biologic validation. Still, this paper likely represents the beginning of a more standardized framework for refractory septic shock research and clinical communication. In practice, this means intensivists may soon start speaking a more consistent language when describing the sickest septic shock patients, especially in trials, escalation decisions, and multidisciplinary ICU discussions. Incidental pulmonary nodules may represent one of the biggest missed opportunities in modern lung cancer detection. That is the central argument of a new review published in Respiration titled Incidental Pulmonary Nodules: What Should We Do in 2026? This paper functions less as a guideline update and more as a systems-level call to action. The authors argue that while lung cancer screening programs receive enormous attention, incidental pulmonary nodules detected on routine CT imaging may actually represent an equally important pathway for early cancer detection. And the numbers are striking. Incidental pulmonary nodules are now identified in up to 50% of thoracic CT scans. Around 10 to 20% require additional evaluation, and approximately 1% ultimately represent early-stage lung cancer. That may sound small initially, but when you consider the sheer volume of chest CT imaging performed globally, the scale becomes enormous. The paper highlights an important limitation of traditional lung cancer screening programs. Even in the United States, only about half of patients ultimately diagnosed with lung cancer would have met standard screening eligibility criteria. That means many future lung cancer patients are effectively invisible to current screening strategies. The review also discusses the increasing recognition of lung cancer in never smokers. In some regions, particularly parts of Asia, rates are surprisingly high. A Taiwanese low-dose CT screening study cited in the paper found a lung cancer detection rate of 2.6% among selected never smokers, more than double the detection rate observed in the Nelson trial screening population. But the most educational part of this paper is probably its discussion of why pulmonary nodule management remains so inconsistent. The authors review major guideline differences across organizations, including the ACCP, BTS, Fleischner Society, and German S3 guidelines. And honestly, this is an area many clinicians underestimate. Different guidelines use different size thresholds, different risk models, different follow-up intervals, and even different measurement techniques. One guideline may recommend a 3-month follow-up CT for a 5 mm nodule, while another may recommend no follow-up at all. That inconsistency creates confusion not only for pulmonologists and radiologists, but also for primary care physicians, hospitalists, and emergency clinicians who frequently encounter these findings incidentally. The paper also addresses an important misconception. Many clinicians still think incidental nodules are primarily a radiology issue. They are not. They are fundamentally a systems issue. The major barriers are often workflow failures, lack of automated follow-up systems, inconsistent patient communication, and fragmented ownership of longitudinal tracking. This article is best classified as practice reinforcing, but potentially strategically important. It does not introduce a new diagnostic algorithm, but it strongly reinforces the need for structured incidental pulmonary nodule programs integrated with lung cancer screening infrastructure. In practice, this means hospitals and pulmonary programs should probably start treating incidental pulmonary nodules less as isolated radiologic findings and more as a population-level early cancer detection strategy. That's it for this week's episode of This Week in Pulmonary and Critical Care Medicine. This week's papers remind us that many of the biggest advances in medicine are not always new drugs or devices. Sometimes they are better definitions, better systems, and better interpretation of practices we already use every day. If you found this episode useful, share it with your colleagues, fellows, residents, or ICU team. And if you want concise weekly updates focused on clinically meaningful pulmonary and critical care literature, make sure to subscribe so you don't miss future episodes. Thanks for listening. Until next week, this is Dr. Aladdin Sagar, signing off.